Good evening, everyone. Great to have everybody on board with us tonight. I'm excited to talk about really one of my favorite subjects, and that is veneers. We want to definitely let you know that this course is sponsored by DenMat, and they are covering a little of my honorarium, all of my honorarium this evening. I do have a practice here in Atlanta, Georgia. I've been in that practice for over 22 or 23 years. I've practiced dentistry for 35 years now and only 62, so I've got a long way to go. We have a couple of objectives for tonight. My ideas here are to help you to understand different veneer preparation designs, and there's a lot of different things that go into deciding what type of design you should be using for your preparation. I think you need to realize how conservative preparations always help the patient. It helps the patient because we're conserving their enamel, which gives us a much better surface to bond to, and it gives us less sensitivity, as we'll be able to see with some of the preps that we'll show you tonight. And then finally, I think we'll look at the occlusal limitations. Different patients with different occlusal schemes, different arrangements of teeth that some people would say you can't do veneers for. I think I'm going to be able to show you a couple of ideas that you can do those veneers for those types of people, even somebody with an end-to-end occlusion. When we talk about preparation, I believe there are three levels of preparation. There's the no preparation, which really is an additive only type of thing. And if the teeth are in a perfect position, if they're maybe a little lingually inclined, you can add to the surface, just like if you're adding to the surface of a cabinet in your kitchen. It's a no preparation, and we'll show a couple of those. My favorite is the strategic preparation, which is really as minimal preparation as humanly possible. And that is just barely touching the enamel in the places that need to be touched. And I'll show you a couple of those this evening. And then we have the full or the ideal. I don't think ideal is the right word for this. A full preparation is really a moderate to severe preparation, but the best thing about it is these can give you the optimum aesthetics. When we say optimum aesthetics, it makes it easier for the technician to give you optimum aesthetics, but it's not absolutely necessary. So when you have a case like this, where you've got lingualized teeth, a small arch form, and diastemas, this is perfect for additive only or a no preparation. When you've got something like this, where you've got a central incisor right here that is angled, you see how the distal of that central incisor is overlapping the lateral. You're going to have to release that a little bit and remove that overlap on the central, so that you're going to do some minimal or strategic preparation there. And on a case like this, I'll show you what I like to do, and that is just to put a small chamfer right at the gum line. And we'll either do those supragingival, which we'll show you, or subgingival. And then finally, where we've got a full or an ideal preparation. When you've got somebody like this with really dark teeth, and you've got to build something on there that's going to be aesthetic and not too opaque, you've got to prepare those teeth. Otherwise, things are going to not look too pretty. But notice, we have not removed the interproximal contacts because it makes it so much easier to not have to replace the interproximal contacts. We've got good flossing. Floss holds on all of these teeth, so if we remove all those contacts and try and build them back in, we all know that whenever we're trying to build things back in with man-made materials, sometimes the contacts come back from the lab and they're not perfect. So if we can hold on to our contacts like you see here, that's always a great way to go. When we talk about a no preparation, take a look here at this, and you can see that this veneer is very thin right at the gum line, and it stops right at the incisal edge. So if you're thinking of doing a no prep case, you can either do this, or you could always wrap onto the lingual surface as well, and I'll show you the preparation design for that. but that would be a no prep case. And the greatest thing about this is you've left all the enamel, you've got a perfect substrate to bond to. And I have had veneers now on for, not on myself, I had mine done, but my veneers for patients are now lasting in the 28-year range. This is the easy way out. When you prepare a tooth like this, it's just not necessary most of the time. Or if you prepare a tooth like this, where you're removing all of the facial surface, all of the mesial, all of the distal, but you're only leaving the lingual, is that really a preparation for a veneer, or is that a 3/4 crown? And I know there's many people that talk about the idea of prepping cases just like this, so that you are getting almost a 3/4 crown. And aesthetically, you can get some amazing results, but are you doing the right thing? Because you've got loss of adhesion, you and I both know a crown just on dentin doesn't hold on as well as an onlay or a veneer totally in enamel. And there's a potential for more sensitivity the more tooth structure that we remove. So our goal is to try and do as little tooth reduction and save the enamel as much as possible. Just remember that the more we prep, the more freedom we allow those technicians to layer porcelain, change line angles, et cetera, et cetera. One of the things we'd like to show you this evening is how a good technician, or even average technicians, if they're using the right techniques, can give you veneers that look amazing without reducing a lot of tooth structure. So the minimally invasive smile design is the way we'd like you to look at the idea of doing your veneers. Less tooth reduction does give the technician tighter tolerances, and it's a little more difficult for them to do. But I've been working with DenMat and the Lumineers, gosh, for at least over 6 years now. And we'll show you some of the cases that are just gorgeous. You've just got to work with the lab. You've got to involve the lab if you're going to do a minimally invasive smile design. And that's the beauty of it. They want to be involved. DenMat wants to help you by sending your case in for a diagnostic wax up. This was a case I just placed about 2.5 weeks ago. Take a look at these veneers, just upper veneers only, minimally invasive, or I would say strategic preparation, as you'll see. Take a look at the tissue. This is the tissue after 2 weeks of healing. Look how clean that is. Look at how the papillae are nicely proportioned right within exactly where they're supposed to be. Look at the glossiness, the light reflection, the translucency. These were done in the DenMat lab. I live in Atlanta, Georgia. I send these cases to Los Angeles or outside of Los Angeles to do these. And I hope you can see this. This is a little tough. I took these photographs. The top photograph is of his teeth before I began the preparation. The bottom photograph is the prepped model. And that is what they built the veneers on. One of the things that you can see is you'll notice that on the 2 central incisors, the little chips there, he had some bonding in this position here. I did want to remove that, and we're going to talk about old restorations. What do you do with old restorations in your preparation design? But if you look at the top, look at the bottom, you can see that we really did minimal preparation on this case. I believe there's lots of determinants for veneer preparations, and we're going to discuss them all. You know, patients come in and they request certain things. There's the lip line you've got to think about, definitely got to think about occlusion, et cetera, et cetera. Let's look at each one of these and find out how we can design our preps knowing these things. So when the patient comes in and requests a no prep veneer, if you're a member of the SDP program with DenMat, they advertise for us. So I have patients coming into my practice asking me for a Lumineer with no preparation. The greatest thing about this is they've already gone to the website. They've learned a lot about the type of teeth that they want, and I get this quite often, the no preparation type of situation. They realize that I can probably do this without anesthetic, and they're willing for some possible aesthetic compromise sometimes. Then there's the minimal preparation, the patient that comes in and says, all right, I'll let you touch my teeth a little bit. They're going to give me some leeway, just like the case I just showed you. And that's my favorite. Usually if they come in with asking for no preparation, it's going to be a very tight situation, meaning there's certain cases that we can do that on. We'll talk about those. The last one, if you have the patient that's too involved in their desired aesthetic outcome, you got to beware. Let me show you this young lady. I'm working her case right now. We took some molds of her teeth. She sent me this letter to tell me some of the images that she would like or the things that she wants with her smile. And I specifically did not show you her face because she hasn't given us an opportunity to use her face. But you look at her teeth, she's got 6 veneers right now that she wants changed. We did a diagnostic wax up. I thought it looked fantastic. I showed it to her and she wanted to see it on the computer, which we did. And she starts sending me these kind of these notes. She's actually done all of these measurements to show me that the wax up may not have the right angle for the central incisors, that the gums, she wasn't totally happy with that. The tooth shape, she wants some changes. And she even went to the golden proportion. You've got to be careful with these patients. You've got to be able to read your patient from the very beginning. If you don't read your patient from the beginning, you give them an estimate for what you're going to be doing for them, and you have a patient like this, you're going to be in trouble. Let's take a look at lip lines. If you've got a patient like this with a high lip line, you're going to need to do a subgingival margin, a translucent veneer, so it looks really nice, because if it's too opaque, it's not going to look good. If you're doing a medium lip line like this gentleman, you can use a subgingival margin, or you can do yours at the gingival area. And I apologize that you're missing the word gingival there. But when you've got a case like this, you can prep subgingival or supergingival. I like doing these right at the gum line, and I'll show you a case that we did just like this. And then finally, when you have the low lip line, you can do anything you want. I like to do supergingival preps on these. There's no reason to use cords. There's almost no reason for anesthetic. And when you take a look at this particular veneer going on, a low lip line, take a look at where that margin is. That margin is right in the middle of the tooth. There was absolutely no reason to do a preparation all the way at the gum line. That's my own veneer on my own cuspid. Now, when we look at occlusion, many of us have patients that are bruxers and clenchers. I always, and I'll say that 100% of the time, when they are a bruxer or a clencher, I tell them they really should have a night guard or wear a night guard. Most of the folks will tell you whether or not they will wear a night guard. Usually, if they've never worn one, I'll ask them if they've worn a retainer before after orthodontics. Some people will tell me, and especially men will say, absolutely not. Never wear the retainer. That's why my teeth look like the way they do, and I'm not going to wear a night guard. Should I not get veneers? Well, I talk with them and explain to them that there's a way that we can give them veneers and still not wear a night guard. If the patient refuses to wear a night guard, you've got to make sure that you keep the same incisal length. That's the most important thing to do. Or if you increase the length, I'll show you a way to do that. So bruxers and clenchers, make a night guard. If you're going to lengthen a bruxer and a clencher, do something like this, where you make sure with your addition of your veneer, you've got a 45-degree angle at the incisal edge of the upper, and you've got to change the incisal edge of the lower. So when they go into a protrusive movement, they can easily slide backwards and forwards. I used to use this when we did all of our veneers in bonding, and I was able to lengthen central incisors by doing it this way. This was a trick that was taught to me by my dad. Gosh, Ron Goldstein, probably before I was on, actually 30 years ago when I'd been working with him. And I mentioned to you about the end-to-end patient. If you've got a patient that is end-to-end, almost class 3, you've got to make sure that your veneer does not overlap and go over the incisal edge that we would use for an end-to-end person. Notice the preparation has a chamfer at the cervical and a chamfer right at the incisal edge. So what happens is an end-to-end person or a bruxer could use this type of preparation. They can still brux back and forth and not worry about breaking those veneers because they're still right on their own enamel all the way as they glide forward. Very important design right there. And we cover the facial only. Naturally, we're going to go in approximately so that it looks nice, but we're covering the facial. We are not wrapping these veneers. These are a little tougher to do because there's no incisal wrap that helps you to seat these veneers, but you can do it. Under occlusion, I want us to just quickly discuss vertical dimension. I'm assuming in all of the cases we're doing tonight that we are remaining with the same vertical dimension of occlusion. And certainly if you've got a patient that comes in with TMD problems and you need to have a new relationship considered for them before you get started, you're either going to place them in temps for at least 2 to 3 months and verify that they're comfortable, or get them to a TMD specialist first or treat it first before you make the veneers. Let's talk about arch form and individual tooth position. If teeth are too far buccal, you've either got to prep it or move it. What do I mean by that? If the tooth is angled forward out of alignment, you can either prep it down if it's not sticking out too far, or you might have to move it with orthodontics. So take a look at this gentleman. He came in with this lateral incisor that's rotated, and you can see from the light reflection on that lateral, it's sticking out beyond the central incisor. So that tooth is too far forward. What are we going to do? He wanted as minimal prep as possible. So what I did with him is I took some, oh, excuse me, this is what you could do. You could use orthodontics. This is DenMat's new Ortho Clear. It's just like Invisalign or the other brands out there. But I love the fact that I can now do everything with one company. So Ortho Clear, I just started my second case this week. Going back to this gentleman, what we did is we took some composite resin while he was in the office having his teeth cleaned. I took some composite resin, placed it on this tooth and on this lateral just to show him what it would look like if we closed those gaps. He was so thrilled because he had been to a previous dentist that told him he needed 10 veneers to realize a beautiful result. We talked him in, we didn't have to talk him in, excuse me, he talked himself into it. When I just showed him this, just the quickest bonding, it took 5 minutes, right at the hygiene visit. And here's what he looked like. And here's his after picture. We finished these in 2 weeks. Super simple case to do. If you've got these types of things in your back pocket, do a little bonding right at the chair. Save some of your old bonding materials. Most of us have old carpules of different colored composites. Don't throw them away. I use those and use that to show a patient what it might look like. Sometimes I can do a mock-up right at the chair. So what if you've got a wide arch? If you've got a wide arch, somebody that's showing a lot of teeth, they're just not pretty teeth, maybe discolored, turned a little bit, whatever. You've got to prep those wide arches, because if they're already showing too much and it's a big wide arch, you've got to bring that back in before you try and place veneers on there. Otherwise, if you do a no prep case, it's going to be even wider. It's not much. You know, these veneers, the Lumineers are, you can get them as little as about half a millimeter thick. But when you put that all the way around, it's going to look funny and feel funny to the patient. So wide arches, I definitely suggest that you prep. What about a small arch? Definitely can be a no prep case. Or diastemas, if you have multiple diastemas, or lingualized teeth, those can be a no prep case. Let me show you one. Here's a case. This is from Dr. Harnoy. And take a look here at the diastemas. And look over here, they're closed with 6 veneers, but can you really tell the difference in the thickness there? There's definitely a difference, but is it so significant that a patient can't handle it? I don't believe so. I've never in all of my years had a patient come back and say, it feels so big, so wide, I can't stand it. My lips don't like it. Now, naturally, it's going to take a day or two for this to happen. They're going to have to need a day or two to get used to it. But that's okay. They're always going to get used to it. Take a look at this young lady. Look at her anterior 6 teeth. She's got a little lingual occlusion on her left side, and she's got a small arch in the front. So we use these images. These are the LumiSmile images that I was mentioning before that come with the SDP program. It's part of DenMat's way of helping you to do more dentistry. We take photographs of every single one of our patients. We show them in about 20 minutes while they're still in the office, this picture here of if they just bleach their teeth, or this picture here if they want to have veneers. And now DenMat's doing the same thing if you want to do orthodontics. You can show a picture of them doing orthodontics. We actually send this to our patients so that they can have a copy on their cell phones, and we don't put the word, the silent motivator there. I'm using that for you guys to show you that when patients see how nice their smile can look, we call that the silent motivator, because they've got it on their phone. They're going to take it somewhere. They're going to show their friends, their family. They might even put it on social media. Please make sure, though, that when you do this, also write down here, add your name and phone number. So wherever they send it to, somebody's going to know how to get in touch with you. We offer these, believe it or not, to any single person. We put it on our website. Anybody that ever sees our website, and we have a landing page for it as well, so that anybody in Atlanta, Georgia that wants to see what their smile would look like can come to our office at no charge at any time without an appointment to have this type of smile picture taken. It's so simple. My front desk does it. DenMat has it coming back to you in about 30 minutes, 20 to 30 minutes, and you just email it directly to the patient. When I say that this sells cases, it definitely sells cases. Take a look at her. She came in, we have a small arch, we have the lingualized teeth. I think you can see it a little bit better here. Look at the lateral and the cuspid over here, and you can see her premolar is sticking out. So what we're going to do now is do a trial smile. We sent the case to DenMat. We got a diagnostic wax up. We got a jig to place over the patient's teeth, and we put some resin in there, some nice white resin, to show her what it would look like. So this is a trial smile with tempering material, so that the patient can say, wow, I love it. Let's copy it. That's exactly what I want. Or we can make changes like I was showing you with the young lady that had all of the changes that she wanted to have done. Most people don't want too many changes. The technicians that I've been working with for the past 20 years are just doing beautiful work, and most of your technicians will do the same. And I finally want to show you, this was her Lumi image that I showed you beginning. This is her veneers that were given or sent to her from the very first day. And this is the final case. Many doctors, as I travel around the country, will say, well, wait a minute, Dr. Goldstein, when you show somebody an image of what you think you can accomplish for them, how do you know you can accomplish it? I've trained my front desk to be careful about what they show the patient. And if there's any question whatsoever, I see these photographs before the patient does. And typically, by the end of their hygiene visit, my staff brings me the picture. I look at it before I show the patient so that I know that I can accomplish what that image shows. And this is extremely typical for us to go from the Lumi image to the final result. And you can see the final result always looks better than that Lumi image because it's a computer. But it really helps. So we tell our patients, you know, you test drive a car, people try on a dress or a suit, why not try on a smile? And with that, as I mentioned, we get so many case conversions over the past 6 years. It has drastically improved the amount of cosmetic dentistry we're doing. And it's not just for veneers. When you show somebody how their smile can look and the improvements that can be made, you're going to be doing more bonding, more cosmetic reshaping of teeth, more bleaching, anything that can help a patient to get a better looking smile. When they see it, they want it. Think about it. When you go and you drive a great car, even if you can't necessarily afford it right now, you're always thinking about that car. Or if you go and you're looking at homes, remember how the real estate agent would say, all right, what's your level? And sometimes they'll show you a little bit more. They'll say, can you stretch a little bit more and have this? And by doing that, that's exactly what we're showing the patients. All right, back to where we were before. We're on to color change now. This is if you're prepping teeth and you need just minimal color change, a no prep case will work beautifully. If you need a moderate color change, a no prep case can work, but you might want to check with your lab technician first to make sure that they feel they can do it with a no prep case. And then finally, if you've got a significant color change like that very first one I showed you, preparation is best, or you may have to use more of an opaque veneer or an opaque cement. And we've got some beautiful opacers in our cements now to change the color of almost any veneer. This was a photograph that I found, or some drawings from Robert Margis. An excellent speaker. He's also writes one of the journals, or is the editor for one of the Aegis journals. But these were some of his diagrams that show you if you need a minor color change, you can be up to 0.3 millimeters and only a half a millimeter in the central of that veneer, central area of the veneer. But if you want to have a major color change, you probably need to improve that and go to 0.75 or even 1 millimeter. Now, let me show you something else about this image that is incredible. This is something that we have been using for the past 25 to 30 years now, and that is not wrapping the incisal edge of our veneer onto the lingual surface. We have that flat surface, as you see here, in either one of these. It's just a flat incisal edge for our preparation. We want that because we get a bulk of ceramic. Notice here that he's got a picture showing you it's 1 millimeter of ceramic. That's strong enough to withstand almost any type of movement that a patient's going to make in their protrusive movement. And if you put them in a night guard, that's even better. But that is our standard way of prepping our incisal edge if we're going to improve or lengthen our incisal edge. And here you can see sort of the look of of a dark colored tooth and what a veneer is going to do there. You're not going to end up with something with your tooth as white as this because these veneers are thin, they're translucent. They're going to get some of the color from the natural tooth bleeding through here, which is exactly what you want. That's going to give you a very natural look to your veneers. If your veneer is so opaque that you can't see through it, it's never going to look good in the mouth. We feel that if you've got previous restorations, you must replace or remove any that are old or leaky. If you placed it yourself a year or two ago, you know that you did a good job. I'm fine with covering that. We always want to make sure that we finish our veneer preparations on sound tooth structure. So when I've got a patient that's got an interproximal older restoration, I am going to prep into that restoration and go just past it interproximally so that I end up on enamel for my restoration of my veneer. And all restorations under veneer must be in composite or glass ionomer because you can etch and you can put a little silane on those. That's the newest research. If you're bonding to old composite or repairing old composite in the mouth, etch it before you bond it, use a little silane, and then bond over it, and then add your material to it. So we've been through all of our veneer preparation determinants. Let's take a look at a few other items that we need to consider when we're talking about veneer preparations. What is possible with minimally invasive cases? If you look carefully at this slide, you can see the slight preparation that I did just at the cervical here. Not one bit of the tooth was touched anywhere else. So this could have been a no prep case. As I mentioned earlier, my favorite way of doing things, this is it, a no prep, but the only thing that I'm going to do is to put a scribe, just a small chamfer right at the cervical. And you can see the same thing here on the cuspid. And that's all you needed to do. The reason for that is I like the veneer to have a nice, perfect seat. And I don't like to have to polish my veneers at the gum line. I like to use exactly what the laboratory gave me and just clip off or break off the extra cement that's there, just like if I were doing a crown restoration. If you're seating a crown, you almost never have to adjust your margin, and you can't get that beautiful porcelain, that finish that you get out of the oven if you resurface the porcelain by having to adjust it. So by putting that little finish line there, my veneers fit like a crown. And here's that particular case. You can almost call this a no prep case. She came in from the Lumineer website, asked us to do a no prep case. I explained to her, yes, I could do a no prep case, or better yet, I could do a slight preparation with no anesthetic, and she accepted that. And that's what we're looking at. 0.5 millimeters added to the thickness of the front of her teeth. It's amazing how thin these can get. Many of you might be saying, oh my God, how are we going to put something like this on? Next month, we have another webinar talking about how to seat these types of veneers. So I hope you'll join in for that. When we are doing these types of things and we're putting these really nice finish lines right at the gum line, I like to use loops. These are my favorite loops. I like them because I have a light on there and I'm not attached to a cord. These are perioptics, and I get, usually I'm using the 3.8 or the 3.5s. They are excellent. I've been using these for about 4 years now. Here's that case I showed you before with very minor preparation. Remember, this was the one where we had to remove just on the distal of that central incisor. And if you notice here, when you come straight down, look at that central incisor. We were able to change the cant of that central incisor so that everything looks the same now. We increased the length of the lateral incisors. And once again, this was very minimal preparation right at the gum line, not subgingival. So if your patient can handle slightly imperfect teeth, then keep the enamel. And I tell you, I don't think that he's got any imperfection in those teeth. When you look here, there's nothing imperfect about that. But if they want perfect, absolutely perfect teeth, like the lady that I was showing you who wants absolutely perfect teeth, fortunately for her, somebody already prepped her enamel. I don't know what I'm going to find when I take those veneers off, but if you have to remove enamel for those, the best thing I can tell you is use your trial smile. If you're working with DenMat or your own laboratory technician, have them do a diagnostic wax up and do that try-in before you get started. Make sure that the patient knows what they're getting and loves it before you touch their teeth. So there's I believe, a misperception that no prep cases don't work. Why did these no prep cases work or minimally prep cases work? Because number one, the patient was a good candidate. We've taught you all the things to look for when you're looking at these patients. We made sure that the lab agreed that they could accomplish what we wanted before we got started with the case. Remember, years ago, most of us, when we were doing our veneer cases, we never talked to the laboratory. We just prepped the case. We usually over prepped it because we never wanted to get the laboratory sending us a message back, doctor, we need more space. Nowadays, if we work closely with the lab, we can find out there's no guessing. They're planned in advance. So if you do a no prep case, that means you're going to have a thicker ceramic right at the cervical, right? Because you did not prep that little line that I like, that little tiny chamfer at the cervical. What are you going to do? You can leave it, because remember, for a natural tooth, there's always that bump at the CEJ, or you can smooth it with the ET 30 micron diamonds. Those are the aesthetic trimming diamonds. They're from Brasseler, or Comet sells them. A number of people sell them now, but they're 30 micron diamonds. And that's what I use to finish and smooth off those margins if need be. And then I go down to a 15 micron diamond, and then I finally use a 30 bladed carbide to get the very best polish that I can right at the cervical margin, if I do a no prep case. Notice here, I'm sure you can notice I didn't do a gorgeous diagram. I'm not an artist, but this is one of my own renditions. But a couple things I wanted you to see here. Here's my preparation design. Notice that we just have a 90-degree ledge there when we're increasing the length of the tooth. But what I wanted to show you here is what we call the contact lens effect. That's using translucent porcelain to allow the natural color of the tooth to bleed through when you're doing a case that is super gingival or with a high lip line case. With a high lip line case, I like to have the natural color of the tooth, and you can see right here, there's a little color of the tooth that's going to come through. And then my veneer, even if it's 0.3 to 0.5 millimeters, if I use a translucent ceramic in that area, I get the natural color of the tooth coming through, and you almost can't see where the natural tooth starts and, ends and the veneer starts, just like a contact lens. It's exactly what we're doing. So if you look at this veneer right here, look at the edge there, and you see the grayish translucent porcelain. That means we're going to pick up the natural color of the tooth there, so that will look like one of the most natural veneers you could possibly see. That's the contact lens effect. Here is an extremely thin veneer, and notice on the central incisor here where it's already seated, it did change the color of the tooth. Not significantly, but you don't have to be significant to get a great result. Remember, when you've got lingualized teeth, you're bringing those teeth out and everything's a little bit brighter. When all of the teeth are brighter, you get a magnificent change, and you don't want to be so drastic that they look like they're on a Hollywood set. Most of us are not Hollywood stars. So once again, take a look at this incisal edge design, which we call for long-term stability. I want to make sure that you see that this one here is one that we do not do anymore. Many doctors did this where they put a chamfer on the lingual surface. We found that this almost always broke and chipped. So we quit doing this at least 20 to 25 years ago. Our standard way of doing things now is to wrap just to the incisal, just like you see here, or if we have a bruxer or we're doing a no prep case, you can leave it right at the incisal edge, just like this. This is also a great design if you've got a patient that is end to end. If the lower incisors are almost right end to end with the upper incisors, all you have to do is finish your veneer right in that area and don't increase the length, and you're going to have a great result. And this is what that veneer looks like when it goes on. That margin design will last and last and last. I just saw some the other day. A lady was in, they were 20 years old with this design, and the margin is gorgeous. It's still sealed, and we don't have anything to worry about there. I'm going to go a little bit longer because I want you to see how we're going to use this thing called A.R.T, which we call the enamel guided solutions. Because of the fact that we're trying to save enamel, I want to show you how we work with the lab technicians to achieve what we've shown you tonight. When you're doing veneers or you're doing any aesthetic dentistry, you've got all of these things that you have to think about. You need to think about the gradation of color. You need to think about reflective zones, the translucency of the ceramic, the central dominance, the midlines, the cants, et cetera, et cetera. Do you think of all of these things when you're doing your consultations? Probably not. Not all of us can remember all of those things every single day. One of the beauty or the advantage of working with a lab technician is the lab technician is your second voice. They are thinking of some of these things that we may have missed. So when we go to plan our cases, many of these things are not overlooked. We believe in a process called A.R.T, the Additive Reductive Template. And we're using A.R.T. Our technicians are helping us to eliminate over prepping or under prepping. We're not guessing, so there's no anxiety when we're doing these types of preparations. It gives us a blueprint for predictable aesthetic success. And most importantly, when I teach these courses, we do a 2-day course where you get a chance to come in and do some hands-on, and we do preparation of models and teach you how to do our complex preparations. But what it does is we teach you how to make these very complex cases extremely simple. Let me show you what I mean. We believe that the dentist is the architect, that the technician is the builder. But the technician sometimes can help us with both of those things. So remember, when we do things by ourselves, it doesn't always work as well as when we do it with a team. So I like working with the team. And these are the 3 levels of A.R.T. Same thing that we discussed previously. There's the no reduction, where the patient is wanting no reduction of their teeth whatsoever. What you can do is send some molds and photographs to the laboratory, and they can analyze the case for you. If you think it's a great case for it, they probably will too, but they'll let you know in advance if it's not. If it is a great case, what they're going to do is they're going to do a diagnostic wax up for you. Then they're going to send you this clear matrix, and that's what you're going to use for your trial smile. Remember, we said the second level was strategic reduction, minimal reduction, only where we absolutely needed to. When they suggest that, they do the same thing that you did before. They're going to give you a diagnostic wax up. They're going to give you a template so that you can use it for your trial smile, a clear provisional matrix. But more importantly, they are doing one more thing, and that is giving you these green reduction sleeves. They are trying to tell you now exactly what you need to reduce to get the result that they believe you can accomplish with that diagnostic wax up. This takes a complex case and makes it simple. It tells you you're not guessing where you have to remove tooth structure. They're telling you exactly where to do it. So it's just like a reduction guide. Sometimes we've made crowns and the laboratory sends you a crown back and they say, I need you to remove a little bit off the distal here. They're sending you a reduction coping. This is just a larger reduction coping. And then finally, they have the idealized reduction. If you need to do a little bit more reduction on a bigger, more involved case, they're going to, same thing, do your diagnostic wax up, give you your matrix. They're going to give you your sleeves. Usually the biggest case I've ever done is with 3 sleeves. And they're going to give you this colored model that shows you exactly what you might want to do. In yellow, that's the exact same thing that they did with the sleeves. And in orange, that's the freehand area. They want you to remove a little bit more so they can give you a beautiful thin veneer. And you just do that by hand. Let's take a look at a case and we'll finish up in about 5 minutes. So here's a gentleman that enters the office, and believe it or not, this was a sales rep from a company. Remember I told you anybody that walks into our office gets an image. We did an image for him and he liked it so much, he was selling a dental product, that he decided to go ahead and have us do veneers for him. So here's his before and after computer image. And let me show you what we did. So we sent it to DenMat. We got our art back. Here he is the day of preparation. We're using our sleeves. We'd already showed him what it was going to look like. So we're using our first sleeve, and DenMat is telling us to decrease the length of the central incisor on number 9. You can see it's a little longer than 8. They want to remove the distal bulges of the central incisors. That's why you can see this little groove right there between the 2 central incisors. Remember, the distal bulge on those central incisors always is hiding the laterals and never looks, to me, never looks good. I apologize, to me it doesn't. I like my laterals to be totally visualized as well as the centrals, and I like a very straight central. Here we're just removing a little bit more, exactly what the sleeve shows us. You can see how the central incisors are straight now on the distal aspects, and we've got a space interproximally there, so they can wrap those veneer. That particular case, they want to wrap that veneer. On the 3rd sleeve now, they felt that the cuspid, as you can see right here, that cuspid was just too bulky. So they wanted us to remove some from the cuspid, which we did. And we're using, this is the Brasseler veneer kit. This was a kit that we designed years ago. Gosh, probably, I want to say about 30 years ago. And when we did this, we were the first to make these little burrs here that will go through and give you about 0.5 millimeters of reduction on the facial surface of a tooth. And then all you do is finish it with these diamonds, and you'll get an exact finish that you need for a preparation if you've got to do a more idealized preparation like you see here. Here we've got the grooves and the central incisors going all the way across. We're continuing our preparation, and I put this slide in. You're going to see in just a moment a great slide of what we do with our patients. Our patients, many of them are undergoing martini dentistry. Love the word martini dentistry. That's nitrous oxide. But when you say nitrous oxide or laughing gas to a patient, they don't know what that is. But you say martini dentistry and they get a chuckle and they want to know more about it. So most of our patients are using martini dentistry. We're finishing our preparation. And this next slide, you're just going to see what a typical patient is doing in our office. Notice the TV at the very top of the screen. They have a TV with headphones, and so they can watch whatever they want, as loud or as soft as they want. And when they are under martini dentistry, they are in a zone, and they really love coming to our office. I highly suggest using nitrous oxide. It's a very inexpensive thing to do, but patients love it, and we get referrals from other patients just by having these TVs in the ceiling and the Martini dentistry. Here's our preparation for this gentleman. Notice how clean those lines are. You've got to be able to visualize your preparation line exactly. If you can't see that and it's not clear like this, don't bother to take an impression. It's just not going to work. Here we are with our flowable material. This is Splash. This is another DenMat product. And you can either air blow it into the sulcus. I've totally eliminated that step. This particular product just washes right into the sulcus beautifully. When we put the putty over it, it pushes it up into the sulcus with some hydrostatic pressure, or hydrostatic pressure, and we get an amazing impression almost every single time. This is our temporary matrix that we're going to be using now. We're placing the material right in there. This is perfect temp. Here's his provisionals. We sent a picture to the laboratory. So here's his before, here's his provisionals, and the after result. And we'll go one more, and let me show you his image. Here's his before picture, no preparation. This is the image that we showed him we thought we could accomplish, and this is his result when we got finished. So once again, you can see that we're able to accomplish what we tell patients that they want, or what we believe we can accomplish on these images.